Hi, everyone. I want to welcome you to our training today with Dr. Guido Frank. The eating disorder the topic is why don't you just eat? Understanding the role of brain reward circuits in eating disorders. We're really excited to have Dr. Frank, but I first want to introduce you to Dr. Kim Dennis. Dr. Dennis is a board-certified psychiatrist. She's certified in eating disorders and board-certified in addiction medicine. She's the co-founder, chief medical officer, and CEO of SunCloud Health in Chicago. Amazing clinician, and really enjoy working with her as well. So Dr. Kim, I'll let you introduce Dr. Frank, and looking forward to a great training today.
Wonderful. Thank you, Tammy. Hi, everyone. Thank you so much for joining. I know we'll have probably a slew of other people joining as we go along. I'm Dr. Dennis, Kim Dennis, and I'm in cold Chicago, and I'm the co-founder of SunCloud Health, who has locations in the Chicagoland area for day treatment, intensive outpatient treatment, as well as residential treatment for complex multimorbidity, including eating disorders, addiction, and primary psychiatric illness. We also have a PHP and IOP program in Gaithersburg, Maryland. And one of the things that is of great interest to me as a clinician who's been treating eating disorders and addiction for the last 20 years is following the research, and particularly research that has very tangible translations and benefits to the clinical work for the patients that I see day in and day out. And one of the researchers that I've been following for some time now, and I'm delighted to be able to introduce to you all, is Dr. Guido Frank. Dr. Frank is a professor of psychiatry at the University of San Diego. He's board certified in child and adolescent psychiatry. He earned his medical degree from the Ludwig Maximilians University in Munich. He trained in psychosomatics at the Center for Behavioral Health, Klinik Roseneck, Prien, Germany, and then at the Western Psychiatric Institute and Clinic with the University of Pittsburgh and the University of California, San Diego, where he is currently. Dr. Frank is a clinician researcher who has studied the neurobiology of psychiatric disorders for the last 25 years. He's also a trained psychotherapist and applies neurobiological knowledge to inform psychotherapeutic treatment. In addition, he's an expert consultant to local and national law firms. He is funded through the National Institute of Mental Health and numerous private foundations for the past 15 years, studying the biologic domains that underlie eating disorder-related behaviors in youth and adults. His research has introduced computational modeling to the eating disorder field. His overarching goal is to develop translational models that bridge clinical presentation with neuroscience to develop more effective treatments. And without further ado, I turn it over to Dr. Frank to talk to us about the relevance of reward circuitry in eating disorders.
Thank you so much for this very kind introduction. It's really excited being here and being able to present to you all about this topic and share the work that we have been doing. And as you mentioned, I'm a trained psychotherapist, which I was before becoming a psychiatrist. So I'm the ultimate in-between person, I feel like, who really wants to bridge what we see in our practice and who we work with on an everyday basis and with the lab, and then translate that back. This is really what excites me. And I think we have been able to develop a model that's very applicable. And I hope that you also find this relatable to the work that you are doing every day. This really important work with these really very ill patients. Why don't you just eat? This is a question that I have often heard patients or parents of patients rather ask them, loved ones ask their spouse or relative with an eating disorder. And I think it reflects how difficult these disorders are to understand, right? They go so contrary what nature typically tells us. Folks who starve themselves to death, people who eat large amounts of food and then throw them up. So it reflects, I think, this really stark difficulty to understand what might be happening here. And I think, if we're honest, sometimes even clinicians who we have been doing this for quite some time, right? So these thoughts might come within ourselves sometimes too, right? When we feel like we hit a wall, it's very hard to get through to somebody. Although, of course, we wouldn't say that, but I think there's so much we still have to learn and understand to come up with more effective treatments. And I'm hoping that this talk today will help you form your own thoughts based on this model that I will describe. Within the learning objectives, I would like to show you how fear of eating interacts with brain reward circuits. So how conditioned fear then really utilizes, hijacks, I would like to call it, these brain reward circuits in a dysfunctional manner. I would like you to be able to describe how food restriction or binge eating can alter brain circuits. What I often tell my patients is the way how you eat changes your brain, and it's then very hard to go back to the normal range, if you wish. And then I'm hoping that you will see how fearful conditioning has long-term effects on treatment outcome. This is really important, and sort of like, what is really the mechanism that people may gain or may not gain weight, and what are the circuits that we maybe have to look at most. So let's start with eating disorder subtypes. I'm sure you're all quite familiar, but I thought for sake of being comprehensive, I thought we'd just review those briefly. And there's, for one, of course, anorexia nervosa, which is characterized by restriction of energy intake relative to requirements, a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. So these people starve, typically lose a large amount of weight. And despite this weight loss, they have an intense fear of gaining weight or becoming fat, even though being underweight. And it's really, there's a subgroup of people who are in the restricting type who really have sort of a psychotic quality. It's a person named Konstantopoulos who researched that a while ago. And they found that they really lose touch with reality and see themselves as fat while they're in this underweight state. On the other hand, when you really drill it down with people, they know they are not fat at the moment, but just the idea of becoming fat is just terrifying. And, like here is underweight and here is fat. And just the idea of gaining a couple grams is just too stressful for them to eat more than what they have been. And then there's this particular disturbance in the way how one's body shape or weight are experienced. So people feel themselves as fat, but it seems like it's less, as far as we can tell, less of a perceptual biological problem. It's probably more driven by these fears, eating disorder related fears, although we cannot exclude that certain maybe visual circuits are also involved. We are starting to research that in my lab now. And then, of course, self-evaluation is very highly determined by shape and weight. And those folks, they don't feel being ill. And that makes it so hard for them to engage in treatment. They sit in front of you and say, no, I'm good. I want to go home, but I have a BMI of 15. Then there's bulimia nervosa, characterized by recurrent episodes of binge eating. Those folks have a sense of lack of control over eating and might then have maybe amounts of 1,000 calories, 2,000, 3,000, 4,000 calories that they ingest in one sitting. And this is followed by recurrent behaviors to prevent weight gain, most commonly probably self-induced vomiting, but there's also misuse of laxatives, diuretics, enema, and so forth. What I notice is often overlooked is the non-purging type of bulimia, folks who have binge eating episodes, and then in response to that, they excessively fast and or exercise the same the next day to make up for that. And that category is often not categorized as bulimia nervosa, which I think is important. And those episodes occur at least once a week for 3 months, and also their self-esteem is very highly influenced by body weight and shape. And the distinction from anorexia nervosa, of course, is that those folks are at the normal to high weight versus folks with anorexia nervosa underweight. Then there's binge eating disorder, essentially bulimia nervosa without the compensatory behaviors. The binge eating episodes are here more defined, with eating much more rapidly than normal until feeling uncomfortably full, but not feeling physically hungry. Folks feel alone and feel disgusted and depressed afterward. And they have very high distress. And I'm really glad we have this as a real diagnosis now in DSM-5, because these people are really very distressed as well. And then there's the other specified feeding and eating disorders category. And we get into that in a moment more. These are people who do not tightly fit the categories for anorexia, bulimia, nervosa, and so forth. They are maybe not quite as underweight. They don't binge or purge as often as required for, let's say, bulimia or binge eating disorder. But these people are also very ill and suffer quite a bit. So I'm very grateful, I want to say, that we can treat these folks now. And lastly, there's the avoidant restrictive food intake disorder category, the newest category really included. Here, those folks are also not eating properly. They may be underweight or have nutritional deficiencies, but they are not afraid of gaining weight. They're not afraid of being too fat. And there are these 3 subgroups that more or less overlap. There's the group which simply says, oh, I'm just not hungry, I'm not going to eat this. And then there's the other subgroup who has issues with texture. They just don't like the smushiness or the crunchiness or whatnot of the food, somewhat reminiscent of maybe autism spectrum disorder. And then there's a third group, I believe that's the largest one, as far as we can tell, that are afraid of aversive consequences. And that could be very often fear of choking, fear of throwing up. They had an experience like that often in younger children, or they saw their brother or sister throw up and they get terrified by the idea, and then they cannot eat properly anymore because they're so overwhelmed by that. So briefly, let's go into epidemiology and comorbidity. So here is, I'm a child psychiatrist, so I like to show particularly data on adolescents. And you see that from this survey a while ago, there is an overall prevalence of about 3%. And you see that it's about more than twice as many in females compared to males. And then importantly, you see how the prevalence increases with age. So it gets more over time. And this is a study that I think is really, really important and goes back when I just mentioned other specified feeding disorders, feeding and eating disorders, OSFED. So you see the prevalence in males and females, and on the bottom, the lifetime prevalence, your point prevalence, and you see that on the bottom, there's anorexia nervosa in like turquoise, bulimia nervosa in like greenish, grayish, and binge eating disorder also sort of in a darker gray. And you see it's sort of like between 0.5 and maybe 2% in the females, less in males. And then, of course, lifetime prevalence is higher. But what I'm really particularly struck by is the orange line. The orange line is the OSFED category. And when you see how many people have an eating disorder, that's maybe not recognized, that's maybe not asked about, but these people, they struggle. They have a significant problem. And you see in terms of lifetime prevalence in the males, it goes like up to about 13% lifetime prevalence of OSFED. and in the female individuals in the study, over 15%. So this is the bulk of individuals with eating problems, and they don't really get much treatment. So this is really important and really tells us to focus on screening for eating problems, so we're not missing these people because they also struggle quite a bit. Lifetime comorbidity is also very high, but between 30 and 50% of folks with anorexia nervosa have anxiety, mood, impulse control, substance use disorders. This is between 37 and 80% in the bulimia nervosa group, and 23 and 65% in the binge eating disorder group. So the take-home message is, if you work with a person with an eating disorder, they more likely than not do have comorbid conditions. And in the past, there was the idea that things will sort of fall into place and will maybe even go away in terms of depression, anxiety, if people recover from the eating disorders. But I don't think that's the case. Many or most have a pre-morbid anxiety disorder that's striking. Very often we see social anxiety disorder and generalized anxiety disorder. And then depression may develop during the disorder, but becomes then its own entity. So I'm a very strong proponent of treating these comorbid conditions as indicated, as much as we can see them independent from the eating disorder per se. And even if treating anxiety depression is not necessarily making the eating disorder better, we will improve people's quality of lives. That's why I think it's really important that regardless if it makes the eating disorder better immediately or not, it's important to treat those to help people simply feel better. And then treatment varies. About half of males and 30% of females with anorexia receive treatment, but half in the female bulimia group and 30% in males, so it's reversed, and about the same for binge eating disorder. So I don't have to tell you that since you treat those folks, but for everybody who does not treat eating disorders all the time, it's really important to screen and help people receive treatment. Lastly, on statistics, about 30 to 74% of risk for eating disorders is through genetic heritability. They're among the deadliest mental illnesses, second only to opioid overdose. Over 10,000 deaths each year are a direct result of an eating disorder. About 26% of people with eating disorders attempt suicide, and the economic cost is staggering. And then especially in the Black, Indigenous, and people of color group, there's a lot of under-recognition. And in that group, folks are significantly less likely than the white people to have been asked by a doctor about an eating disorder. It was like in the past, the idea of folks with in the African-American demographic group, they don't get eating disorders, but that's clearly not the case. Black people are less likely to be diagnosed with anorexia nervosa than white people, may be ill for a longer period of time. Black teenagers are 50% more likely than white teenagers to exhibit bulimic behavior, and Hispanic people are significantly more likely to suffer from bulimia nervosa than their non-Hispanic peers. So really important, again, that we ask and refer to treatment. And lastly, for the LGBTQ+ group, that group very often uses eating disorders to modify their body. So if you work with those folks, then be very specific, asking and see how they may be trying to become their the gender that they feel most comfortable with eating disorder behaviors. Gay and bisexual boys are significantly more likely to fast, vomit, or take laxatives or diet pills to control their weight, for instance. And 30% of transgender people report using their eating disorder to modify their body with hormones. So that is a very high likely having an eating disorder group. So having said that and setting the stage on the population, let's move to neurobiology. And I'm sure you have the same experience that eating disorders are very often chronic. And the behaviors go from food avoidance to binge eating, purging, excessive exercise, and back and forth. People might have one disorder and then they might cross over to another and maybe back. And these behaviors cause a lot of problems, right? These people land people in the hospital, cause severe kidney damage, all kinds of deleterious effects. Yet, it is so hard for folks to disengage from that. It is so hard for people to get past those behaviors. So I'm always thinking there must be some intrinsic motivation to perpetuate, excuse me, those behaviors. And when I say intrinsic motivation, I'm not necessarily thinking about a volitional process where people just want to do that consciously, but there are probably biological mechanisms that drive these behaviors and that are so difficult to overcome. And when I draw pictures on the whiteboard in people's hospital rooms, then I often point to these pathways and say, look, this is what we're up against. So, and that's what I would like to get into with you now. So how can eating disorders happen, right? I already talked about how difficult, let's call it, to understand it is, how people might restrict their eating to the point of death, binge and purge. And in the next slide, I'd like to show you an overarching hypothesis and model that we have based our work upon. So the way how we look at this is it's usually some trigger. And the trigger can be many things. The trigger can be simply summer, and the kid wants to get better in running or playing soccer, maybe get an 18 next school year, and then starts exercising more. And I just have a kid right now who had absolutely no eating disorder issue, always has been thin, and there was no problem, and she wanted to get on the track team and started to run more over summer. And 3 months later, she had severe anorexia nervosa. And interesting enough, there's a pattern in her family. There's 2 other women who just started exercising more, and then something changed in their brain, and now and then this eating disorder started. And interesting enough, body image distortion wasn't really there from the beginning. It developed later. But there are other people who maybe want to lose weight for some reason, who feel they should reduce their weight. There are other people who go through terrible abuse experience and who do not want to feel their body. So the spectrum, what triggers somebody changing their eating, is very broad. There's the RFID group who is afraid of choking or vomiting, right? And they also then change their eating. And most often it starts with some food restriction, then maybe followed by binge eating and purging. Others, they binge eat because they learn somehow that binge eating reduces feeling stressed. And there is animal literature that shows that when you eat especially carbohydrates, then your noradrenaline tone in the brain goes down. And you may know from your own experience, you're stressed and you work on something, and some food, right, is somewhat pleasant, right? Helps you feel better and helps you keep going. So in this process of changing eating, there are 2 key factors that then happen. One is there's a change in expectation and learning. Food and eating become negatively conditioned stimuli for different reasons, right? So you look at food and you feel like, I don't know, right? Because you're afraid of gaining weight or not being able to run as fast if you gain weight or whatnot. So fear of weight gain, becoming fat, choking, throwing up, become then sort of more ingrained. This is what I like to call sort of the motivation, the initial motivation that sort of sets things up. And then second, once you change your eating, there are sort of these non-conscious biological adaptations. There's a change in body homeostasis. There's a lot of havoc that gets created in the GI system, with a lot of GI hormones being out of their usual balance or circadian maybe rhythm. But there also are many changes in brain neurotransmission. So there's less amino acids that end up in the brain, and you make less serotonin, you make less dopamine out of it, and then that has an impact on how these neurotransmitter circuits work and how many receptors there are and how sensitive they are. And then we think that these factors, this triangle then interacts and reinforces itself. And that's, I think, where the real problem then eventually lies. There have been, over the past 10, 20 years, many neurobiological studies that researched brain function eating disorders. With some of these studies that I have been part of as well, including studies that looked at serotonin receptors in eating disorders, and we found sort of pretty stable patterns of elevations when folks with anorexia or bulimia nervous were ill. Serotonin 2A receptor was sometimes normal, sometimes reduced. There's many studies on gray matter volume and cortical thickness, but these are factors that are also highly determined by dehydration and how much you ate that day and things like that. So it's been not that easy to tie those to behavior. Then more advanced studies looked at how do these brain regions connect, right? You see these colorful connections, and this is actually a real brain. This is not an illustration. This is a real brain where these white matter tracts were visualized with color. And maybe higher, lower connectivity has an impact on behavior. We looked at functional connectivity. How do brains sort of swing with each other? How do they get active at the same time? Or effective connectivity is how does one brain region drive another? And then more recently and more in tune, I want to say, with real life behavior, are these task-based functional MRI studies where we look at reward circuits, maybe perception, cognition, and social interaction, and try to understand how behavior in the lab might relate to the brain and how might that relate to the real world. Another problem is really that creating this holy grail from eating disorder behavior to regions that are involved, to circuits that are involved, and mechanism to disease has been really, really difficult. It's been really difficult to come up with comprehensive models. Many of these studies have interesting results, but they're sort of singular. They often cannot be replicated. So it's tricky to have a stable mechanistic approach to these studies. And to further this, we then did a whole set of studies across the years. And then this culminated, I want to say, in the largest study in eating disorders across the whole spectrum that uses functional imaging in a task. And we recruited here 120 healthy controls, almost 100 folks with anorexia nervosa, 34 with OSFED. These were all in the atypical anorexia nervosa category, over 50 with bulimia nervosa, and 16 with binge eating disorder. Interestingly enough, the binge eating disorder group was not as easy to recruit. And we had this idea that there's probably a trajectory of biology that goes from high to low weight to start out with, since weight is something that's easy to measure. And I know there's a lot of discussion how much we should focus on weight and weight stigma and things like that. So these are all important questions to be asked. On the other side, weight has an important impact on your brain. And we know that from animal studies that if you restrict or overeat, you clearly have a change in brain. And that's why we started out with looking at weight and how it may relate to brain function. And we have then since been expanding that to more cognitive, emotional aspects of those disorders. And how the task, one of the tasks that we applied, the main task that works is as follows. It's called the prediction error model. And it tests whether a person receives or does not receive something expectedly or unexpectedly. So people on the scanner, they have tubes in their mouth or a manifold, and they get sucrose solution or artificial saliva or nothing. And then they learn, like in a Pavlovian reward learning task, to associate a conditioned visual stimulus with a taste stimulus. So they are in a scanner, a certain picture comes up, let's say the orange one, and then they receive sugar, or they see this purple kite, and then they receive nothing. However, in 20% of cases, when they think they get nothing, they get sugar. And this is invariably associated with their brain response, a surge within the dopaminergic circuitry. And that's a very highly replicated model in animals and was then transferred to imaging in humans. And similarly, in 20% of cases, when they thought they would get sugar, they get nothing. And this then resulted in this dip in activation. And I like to tell the story that, let's say you have a friendly office mate who puts let's say a piece of cake on your desk one day, then you have an unexpected receipt here. Let's assume you like the cake, and then you have a surge in dopaminergic circuitry. And then if the person does that to you every Monday, then you start expecting that, and when you get the cake, you don't really have much response anymore when you see that, although you still enjoy the cake. But once this person gets sick maybe, and there's no cake on Monday on your desk, then you have this dip in activation. So a little bit of a disappointment response, if you wish. So the nice part about this model is it's so nicely applicable to our real life. And so you can put on the scanner, and importantly, it tests the dopaminergic circuitry. Then whatever we find, we can make inference from to dopamine function in the brain. And the task then also lets us look at conscious expectation learning, this conscious outcome, stimulus receipt, expected, unexpected, or the omission. And then, of course, we look in the brain. And how does the brain adapt to the task and in relation to restriction and overeating? So let's start with expectation learning in this conditioned fear of eating and food intake control circuitry. So I'm sure you have heard about the hypothalamus. The hypothalamus is a tiny region in the brain that's really, really important for homeostatic integration. So what does that mean? It receives information from the body about how hungry you are, how cold you are. Oh man, I need a second coat or something like that, whether you're a sad height or not. And the goal here really is to then drive higher order brain regions to drive decisions, to maintain the organism. And most importantly for our patient population, right, we want to think about hunger and eating. And how does this drive the eating behavior, or maybe not? So on the other hand, what if you have to stop eating? Let's say you are, let's say it's spring, the snow has melted, you hike in Lincoln Park, and you want to sit down and have the lunch you brought, so you're hungry, and sit there and unpack your lunch. But turns out that day from the Lincoln Park Zoo, a tiger has escaped. And the tiger all of a sudden sits in front of you. And most of us have conditioned to the idea of a tiger being in front of us with quite a little bit of fear, right? A tiger is a dangerous animal, excuse me, and it can kill us. Now, the problem is we're still hungry, right? And we wanted to eat our sandwich, let's say. Well, most of us would then, though, value our life and getting ourselves to safety more than sitting there and being attacked, maybe. And there is a circuitry for that goes from the frontal cortex, is fear-driven, and goes to the ventral striatum via dopamine D1 receptors. It's an area that's part of this reward circuitry, and then goes to the hypothalamus and overrides hypothalamic basic drives. Or let's say you are at your desk and it is lunchtime yet again, and you want to eat something, but then your boss comes along and you realize, oh my gosh, I didn't write this note, right? And you might put your lunch away real quick and finish the note. That's a similar pattern here, right? This circuitry then overrides your immediate basic drive to eat. You stop, you finish what's more important in that moment, and then you go back to eating later. So we tested this circuitry in the scanner. We had folks taste sugar and looked at healthy controls and folks with eating disorders. And then we looked at how did these brain regions interact when they tasted sugar. And in the healthy controls, the direction of activation was from the hypothalamus, excuse me, to the ventral striatum. And that is the expected direction based on animal research, transmitting the information about likely homeostasis upwards into your higher order brain regions. On the other hand, the women with eating disorders, they had the opposite direction from the ventral striatum to the hypothalamus. And remember, this is the direction that this food control circuitry activates to override hunger signals, appetite drive. And we replicated this in several studies. So how we then conceptualize this is this: sugar was probably seen as a threat in our model, just like the tiger, and maybe reflects in food, and as it is in generally a conditioned fear-inducing stimulus. And that then triggers this ventral striatal dopaminergic circuitry to override hunger cues. And there's even a second mechanism that is triggered through fear and that directly drives dread and avoidance through the ventral striatum via dopamine D1 and D2 receptors. So this is how fear of eating interacts with brain reward circuits. And I like to call it how fear of eating hijacks these circuits that were meant for quote unquote true dangers, the tiger, right? But it kind of gets overtaken by this fear of eating, fear of gaining weight, and then triggers this food control circuitry. And that's our learning objective 1, and how this sort of like interacts with each other and how it works. Next, we come to these more unconscious biological adaptations, eating disorders and reward circuits. So my lab and others have been studying brain reward circuits to understand food restriction, binge eating, body image distortion. However, brain reward circuitry, I want to call a little bit of a misnomer, because it always implies reward, something good, something that I want, something that I approach. But these circuits actually do a bunch of different things. So they process whether expectations are violated, important for learning. So the reward valence circuitry, which works via dopaminergic circuits. And there's a motivational salience circuitry, which processes stimuli that propel an individual's behavior toward or away from a particular object, perceived event, or outcome. So it's not just approach, it's also avoidance and looking for other options. That's really important. And this reward circuitry also includes neurochemicals such as opioids and things like that. So it's very multifaceted. And the reason why the dopamine circuitry is so nice to study is because it's the only neurotransmitter system where we have a mathematical model, essentially how it works. So it's something that we can look at very, very nicely with our data. And that study in the large group of individuals with eating disorders and healthy controls then lend itself to the following model. food restriction, low body weight eating disorders are associated with a sensitization of these dopaminergic circuits, which is very aligned with animal models. And they then strengthen this food control circuitry simply by elevating the dopaminergic strength, if you wish. And think about it. You want to control your eating, you lose weight, and that then strengthens the circuitry. That creates a real problem, because then it reinforces your ability to further food restrict. On the other hand, binge eating, high body weight eating disorders, we see a desensitization of those circuits, just like in addiction models, very similar. And they then weaken this food control circuitry. And that then opens the door to another binge eating episode. So this is then becoming a vicious cycle. And if we integrate our conditioning and learning aspect, again, we have the motivation to change eating. Many restrict, many sort of turn into food restriction, binge eating, probably depending on your genetic makeup, how easily you sensitize in one or the other direction. And then you have this conditioned fear of eating. Most of those folks that then activate, just by their conditioned fear of eating, the food control circuitry to override the appetitive drive. And we see this all the time, right? Folks with anorexia nervosa restrict very much. Folks with bulimia nervosa, they also restrict often, but only the ones with low weight and the sensitized dopaminergic circuitry, they then perpetuate the food restriction, versus the folks with higher weight eating disorders, they have the intermittent binge eating episodes. And that's then this vicious cycle that reinforces on both ends the eating disorder, making it really, really difficult. And that's, I think, one of these aspects that then get in the way of recovery and that we can sort of talk with patients about. The next aspect that I was particularly interested in is, what about these expectation mechanisms? So expectation drives sort of what we want to do, and expecting food has been researched a little bit in the past, but more from a behavioral perspective, and we know those people are afraid of the next meal and stuff. But how does it work in the brain, and how does it interact with brain reward, or maybe better, motivational salience circuits? Hasn't really been studied. And so then I was wondering, so how does fearful expectation activate brain reward circuits in eating disorders, and how do anxious traits contribute? And I can tell you a story around that. In the past, I had an outpatient clinic, and what I noticed is each August, several of my patients relapsed. And then I thought, wait a second, what's happening here? August, well, August, school starts, right? So it's a high stress time, both socially as well as academically. And somehow the eating disorder finds its way in them. People who had done well really for quite some time. So I really was particularly interested in see whether anxious traits that have nothing to do with eating in the first place, how they interact here. And we thought, okay, this conditioned fear of eating, expectation of a caloric stimulus, should activate the amygdala, right? I'm sure you all know the amygdala is very important for expectation, fear, anxiety processing. And then how does it interact with these reward regions? How important is the expectation with the actual outcome in oral frontal cortex, insula, ventral striatum? And when I started researching that, I saw, oh, that's interesting. There's a person called Nitschke who studied that in the past, and he also looked at aversive stimuli, including taste and pain, and found that actually the expectation had a very important factor here in triggering these reward circuits. So how we think things may turn out has a really important impact how we then actually respond in that situation. And of course, in psychotherapy, we can work on expectation and so forth, and we may then be able to ameliorate, so to speak, the actual outcome. Then further, I thought, so how does trait anxiety interact here? We used the same data set and analyzed separately expected receipt of the sugar solution as well as expectation response to those conditioned visual stimuli. And here what we find is we focus on the amygdala, that all the eating disorder groups had an elevated response to the expectation. And that was really striking. It was only significant in the anorexia nervosa group. If we collapse all eating disorder groups, it was significant on both sides compared to controls. But what we always struggle in psychiatry and imaging is we have small effect sizes. So the differences are not that great. But I think we can say that they all responded stronger to this amygdala expectation, making the case that fear processing is really, really important in eating disorder pathology. And what we also found is that, yes, there was a very strong correlation between amygdala expectation and then the insular receipt, so where the taste processing really happens. And what I was most excited about, trait anxiety moderated how the amygdala expectation and insular receipt response interacted. So there's more to be studied, how it exactly, whether it makes things, how it makes things worse or not, things like that. But this is really the first study that showed that trait anxiety has an important impact how these brain functions interact and how amygdala expectation then interacts with the outcome response. So we're looking into how we can take this then to the next step, but is supporting that trait anxiety is really, really important for eating disorder behavior. And then I always tell patients, well, let's take the middleman out, or middlewoman or whatnot, meaning let's focus on how you can handle your stressors better and how you can handle your pressures in school and social things better. So the eating disorder doesn't find its wedge in anymore. And then there's some other important things. How expectation is a central factor to reward and pleasure in general in anorexia nervosa. So one behavioral study we did, we looked at anticipatory and consummatory pleasure in eating disorders. And there has been long this notion that folks with eating disorders cannot enjoy things as well. And yeah, I wasn't so sure about that. So then we looked at this questionnaire, which separates pleasure experience from anticipatory to consummatory. So expecting something, oh, next week I do this and that, and I can, and how will that be, versus I am in the next week experience, and then can I enjoy that or not? And we had a pretty sizable sample of 124 women with eating disorders and 84 controls. And we applied the temporary experience of pleasure scale. And interestingly, the folks with eating disorders endorsed significantly lower anticipatory pleasure. So they had a harder time with looking forward to things. And when you think about it, generalized anxiety disorder is very common. So this would also make you think, well, maybe that has something to do with it, right? Because there's always something that can go wrong, get in the way. But consummatory pleasure was similar between groups. So people can enjoy things, but the anxiety gets in the way. The anxiety gets in the way. It was inversely related to trait anxiety. And here, I want to show you a correlation graph for both actually the healthy controls and the eating disorder folks. And you see how trait anxiety is negatively correlated with this anticipatory pleasure. So the more anxious you are, just by your traits, the harder it is you can look forward to things. And the beauty about this is we should use that in our treatment. we should think about how can we treat this or focus on that, both from a psychotherapeutic, but also from a medication perspective, right? Can we modify our medication interventions to reduce this anxiety and help people then enjoy things more? And that's, I think, really, really important. And I believe we are the first ones who really separated those different types of pleasure experience and then tied it so directly to trait anxiety. And here we come to a study that we also published recently, where we wanted to look at long-term outcome. So there isn't very much in terms of long-term outcome and neurobiology. Few studies on maybe some gyri formation in the brain, things like that. But again, structural imaging and behavior is very hard to connect. That's why I have been not really pursuing that very much. But what we did here was we wanted to see whether our functional imaging using this taste task, whether that would predict long-term outcome. And I was very convinced that this dopaminergic circuitry would predict long-term outcome in terms of weight, because I thought, you know, it's these dopamine circuits that are either more high or low in the folks with anorexia nervosa, and that should predict it. Well, I was very wrong with that expectation. I looked at the data forever, and there was just really nothing that I could tie to. And I was very frustrated, and then I put this away and just didn't look at those data anymore for a while. And then sort of my interest in expectation and kind of these conditioned fear processes kind of increased, and I thought, well, let's look at expectation, right? Let's look again whether expectation and not the dopaminergic outcome response would predict weight. And that then became very exciting because it did. So expectation, remember, it is when we expect the sucrose, artificial saliva, or nothing based on those fractals, right? So the response to the conditioned stimulus in the orbital frontal cortex in blue, or turquoise-ish blue, really had a very strong correlation with long-term BMI outcome. And these were people we followed for a long time. It wasn't that everybody was then assessed 3, 5, 10 years later. We came up with this idea later during the study. So we had people at different times of follow-up, but we then covariate. So we controlled for the time after the brain imaging study and after treatment, and correlated whether the expectation response was related to long-term BMI, long-term weight outcome. And you see that the more this response was, the higher they responded, presumably the higher their fear response was to expecting this high caloric sugar stimulus, the lower their body mass index was. So while their biology often normalizes these conditioned fears, they just stick like a Velcro, and it's very, very hard to unstuck. And this is a verbiage that I use with my patients as well. And just to make it clear how hard this is and what's happening here, and also normalize it in a way, right? This is just what happens, okay? And now let's see how we can deal with this. And this brings us to our next learning objective. How fearful conditioning has long-term effects on treatment outcome, and the brain just shows us that. So yeah, so expectation, the orbital frontal cortex. So summarizing, the low weight eating disorders, mostly anorexia nervosa, where we have the prefrontal cortex with conditioned fears of eating, weight gain, and they then, by anxiety and fear, drive the amygdala, which becomes hyper-responsive to conditioned threats, caloric food, drives the dopamine response to salient stimuli. The prefrontal cortex also drives the dopamine response to override the appetitive drive. And the hypersensitized dopaminergic circuits, they then become reinforcing in ongoing food restriction because they strengthen this hijacked dopaminergic circuitry. On the other hand, we have the high weight eating disorders. They have the similar pattern: fear of eating, weight gain, anxiety, fear-driven amygdala response, wanting to override the appetitive, wanting to override eating. They have a fear-driven food avoidance, here psychologically sort of, if you wish, driven to not eat, but they have these desensitized dopaminergic circuits, then leading to intermittent binge eating episodes. And that's really a crucial difference. So psychologically, if you will, thinking, feeling-wise, they're usually very similar, but because they have a different underlying biological predisposition, if you wish, that then makes the difference probably why they then land in one or the other eating disorder category. And yeah. So by the way, this is what I do for patients. This is literally what I do for patients. I draw a picture on the brain, just like that. And then I show them how the frontal brain kind of processes these thoughts, feelings, fears, and how they then trigger these circuits, striatum, dopamine, hypothalamus, try to override, and then bring this from out the black box, from this sort of like, what is this? And this is terrible and whatnot, into something tangible. And then you can say, okay, therapy goes here. Medication goes here. Although actually that's not true. Medication goes both ways and therapy also goes both ways. So, but then you can pinpoint, okay, this is what we're working on right now, right? And then it really helps people to engage and then make it theirs, because you want to help them disentangle the eating disorder, like being them, right? You want to disentangle that and then becoming yourself. And then I like to say, let's kick the eating disorder off the boat, or let's let the eating disorder leave and they develop their own thing. So lastly, I want to get a little bit into medications, and I want to make sure I say no medication has been approved for anorexia nervosa, and only one fluoxetine in bulimia nervosa, and lisdexamfetamine in binge eating disorder. But I wanted to use this neuroscience model to help develop a framework. And we published a chapter last year with all those studies that were done across different medications. And really, again, no medication is approved for anorexia nervosa, fluoxetine, bulimia nervosa, which also has its shortcomings, and lisdexamfetamine, binge eating disorder. But in terms of a neurocircuitry-based model, I think what we really can focus on with medication is to think about it as a mediator, something that opens the door to make psychotherapy more effective, improve learning, reduce anxiety, improve mood. And again, we have our model for anorexia, right? With anxiety, thoughts, feelings that have been really hard to target. We can refeed people, so to speak, but they are very afraid. And it's been really difficult. But then we have these dopaminergic circuits, and we have dopaminergic medications. So we have an opening here. The dopamine circuitry is very broad. So everywhere in the cortex, there are the D1 and D5, excuse me, D1 and D5 receptors. And then you have in the hypothalamus the D3 and D5. And then in the reward regions, striatum, the D1 and the D2 receptors. So this is sort of a model where these receptors might work. And there's fantastic work from Barrett's lab that showed that really whether you approach food or not depends on your bias and your conditioned response. And then the top part, the rostral part, is approach coded, if you wish. And the bottom part, it's dread, fear, and avoidance. And which one of those regions you activate really depends on whether you feel safe, non-threatened, or whether you feel unsafe, threatened, right? And we know our patients distinguish food by safe foods or unsafe foods, right? Things like that. And this conditioned fear towards food and eating drives dread and avoidance, likely through this lower part. And we really want to block that, right? These D2, D1, and D2 receptors to reduce dread and avoidance. And on the other hand, we know that, excuse me, especially in an underweight state, dopamine D1 and D2 receptors aid in cognitive flexibility. And this is really interesting. Dopamine D1 receptor in the frontal cortex aids in surveying changes and reinforcement contingency. See, what does that mean? So essentially, what makes sense to pursue, right? What makes sense in my life? And I always like to say to people, okay, let's see that you came from floating under the water, that you get the head above the water. And then you see where you want to swim to, right? What makes more sense? Does it make more sense to stay in the hospital another 3 weeks or months? Because you really have a hard time getting going with the eating. Or does it more sense to work on the eating because maybe there are other things in life? And the D2 receptors seem to help with that. Promote flexible patterns and reward seeking, right? What alternative rewards should I look for in terms of reward, low weight on the scale, or meeting friends and developing a life and stuff like that? So we could use dopamine receptor agonists to promote cognitive flexibility. And we have this clinical presentation of rigid perfectionistic patterns, right? Food avoidance. And then we know from animal research, again, that D1 and D2 receptor agonists help with cognitive flexibility. There's also a little bit of research that showed it may help with weight gain. I told you about anxiety hijacking these dopamine-mediated circuits to override hunger cues. And they are hypersensitive in anorexia nervosa. And again, the animal research tells us feeling safe promotes eating, feeling unsafe promotes not eating. So how can we approach that with medication? So we have then been using the dopamine partial agonist aripiprazole to increase cognitive flexibility at the low dose, because the low dose is more effective, likely, than a higher dose in the underweight state. And we also use the aripiprazole with the idea, and that's more sort of based on animal literature, to desensitize those circuits and eating support via the brain stem. And then we also use the antagonist, the D1 and D2 receptor, dopamine antagonist olanzapine for acute agitation, distress, to reduce dread response. So you might think, well, this is maybe doesn't make sense to have use of both an agonist and antagonist. The olanzapine, we only use as PRN. We only use it when people are getting super distressed, to calm them down, to reduce this distress dread response. It does not do anything for your engagement in psychotherapy. That's the problem. It helps people calm down, but it doesn't help move forward. The aripiprazole is more something that helps move people forward. People say, oh, I just don't feel as anxious on food anymore. Or the best validation in lack of randomized controlled studies that I have is when the psychotherapists, the psychologists say, hey, can you please prescribe that? I think this person needs the aripiprazole. Because they saw in their work something is better. It's not a magic cure. It's not, but it helps open the door, and that's what I find very reassuring. And we did a retrospective chart review, and we still pursue more organized studies, but it's very hard to get money for that. So with that, I'd like to stop and thank you all very much for listening. And I think there's time now for questions.
Yes, thank you so much for a wonderful presentation, Dr. Frank. I have, I see a couple of questions. One just sort of logistical. Will the slides be available after the presentation?
I sent you a PDF file with all the slides, so you're welcome to send that.
Awesome. So we will pass along the PDF of the slides to all the attendees. And then I have a question from Carolyn Stipka. I'm not sure what slide she's referring to, but why was BMI change being used in a previous slide? So, and this is a question I think that comes up a lot, particularly around when I'm thinking clinically of folks with atypical anorexia, right? And I guess, could you talk a little bit more about how you determine, or have you determined weight suppression or percent weight suppression versus, have you looked at that versus solely BMI?
Yeah. So this is really a fascinating question, a very tricky one to to give you detailed data. But so first of all, when I look at the BMI, the folks in the atypical OSFED AN category, they essentially fall right between the underweight AN folks and the healthy controls. So they clearly lie on a trajectory. So that's very much in line with animal research. The more you restrict, the more you change your dopaminergic circuitry. However, where the atypical OSFED anorexia nervosa group and the anorexia nervosa group and also bulimia group are totally similar or almost similar is the expectation, are the fears, are all these cognitive emotional aspects. So they're very, very similar there and would the same in a way. But the reason why I think it's important that we do not discard the BMI as something important is this. The Abilify, or aripiprazole, I should rather say, works as a partial agonist in a low dopamine environment. When you're underweight, you have a low dopamine environment. You have low dopamine in the brain, but the receptors get super sensitized. So there's an imbalance then. And you need the low level of drug. If you, let's say you have OSFED AN, you're just suffering just like everyone else, right? And I want to emphasize that. I clearly recognize that. The low dose of aripiprazole may actually not be helpful. And maybe you need a higher dose. Because then you have to adjust, and depending on whether you're in an underweight or a technically normal weight state, you need maybe more of an agonist versus an antagonist to help with cognitive flexibility. Now, you could argue somebody was maybe at a very high BMI, lost a very large amount of weight, maybe to the 24 level of BMI or something like that, right? And maybe relative to their baseline, these people are in a hypodopaminergic state, right?
Right.
So maybe they're quote unquote the same as another person who lost from BMI 20 to 15, something like that, right? But the data don't show that per se. I have been looking into past high weight, past low weight, and how that relates to brain function. So I have been trying to find out whether I can solve somehow this conundrum, or whether this highest lifetime weight minus current weight, whether this relates to brain function. But that hasn't been very successful. So I think, to be honest, I think the BMI measure is particularly important for current state of the dopaminergic system, which can change a lot depending on whether you gain or not. But similarly important are these cognitive emotion expectation aspects that really trigger the dopaminergic circuitry. So based on the data, I don't think it's good that we disregard the BMI. But there may be things we haven't figured out yet, how this change in weight might need to be approached differently across patient groups. That's I believe that's all I can say really with good questions.
Well, another question for this class of patients that we call non-purging bulimia nervosa, right? That particularly folks that go between periods of, 2 weeks of massive binge eating, and then weeks of restrictive eating. Without any binges, objective binge episodes during those restrictive periods at all. When you think about the interplay of the fear conditioning, and then particularly also the reward, the dopamine response and dopamine responsiveness in patients with non-purging bulimia who are in an average weight range. How do you understand that, those folks?
Yeah, that's a fascinating question. And my hypothesis is it depends on the flexibility or fluidity, if you wish, how these receptors adapt. And my hypothesis is, but this is probably more a genetics question, when we did some genetic work in the past, but we had not enough in the anorexia nervosa group to really make a distinction. But I think folks with restricting, especially type anorexia nervosa, they sensitize strongly. They have a genetic predisposition to sensitize, and then they stay there in a way. And folks with binge eating, bulimia nervosa, who stay in that category, they desensitize, and then they sort of stay there, if you wish. And there was read an animal study a long time ago where they did these knock-in and knock-out studies of dopamine receptors, and then looking at changes, and then changes that then happened, they were permanent almost. They couldn't really go back to normal even when they put back in this receptor. And that's a little bit how I look at it. They are stuck there. Versus the people who maybe the AN binge purge type, or the folks who describe the ones who don't eat for a couple of weeks and then they binge purge again, maybe they have a more flexible receptor system that goes up and down. And that probably is highly determined by an individual's willpower, if you wish. They are very cognitively very strong to then say, okay, I'm going to do this. I'm just going to lose weight, and I'm going to, and then they override this hypothalamic drive. They activate the striatum and override these basic eating drives. But again, they can do this only for so long, because they probably have a weakened, I don't want to use the word weakened because it sounds so negative, but a more desensitized dopaminergic circuitry. And then at some point it says, no, I want this. I just can't keep it together anymore. When you think about the addiction or alcoholism literature, there was an old, I think it was Kanner, who had like an sort of separations of alcoholism. And there was like the type who got violently drunk or severely drunk every month or something like that, right? So they stayed clean, and then they got super drunk, caused problems, and then not again. So I see that as a little bit the same. People stay on track in a certain way, but because of an underlying biology, it just pops up, and then you just cannot control anymore. That would be my hypothesis. But again, that needs more understanding, and maybe, as I said, genetic studies. But these are also hard to do in the small samples that we have. So that's always the caveat.
Right. One final question. You use the term when these things when these patterns get stuck neurobiologically, stuck into place, it's like Velcro, right? What do you think about the potential and some of the data that has come out around the potential use of psychedelics, particularly for people with anorexia or even binge eating disorder.
Yeah, I think this is definitely an option. My understanding is some people respond and others don't. It's not a it's not a magic bullet for everyone. That's my understanding. So from our program, there was a recent publication in a small group, and there's some studies going on. So my hypothesis is that the ones who have a depressive illness might be particularly responding well to that. There's also then the question, how does ketamine, for instance, affects the illness? And it may also be especially ones who have a depressive illness that goes along. And I had several lessons, young adults who, when they recovered from anorexia nervosa, a severe depression came out. And then that sometimes really didn't respond to any meds. And then I sent them for ketamine infusion, and that was incredibly beautiful to see how people then normalized and recovered. So I think, and that's why I think it's so important to look at comorbidity and look at what else is going on to then make the best treatment plan possible.
Yeah, I mean, I think along those lines, we see incredibly high amounts of either full clinical PTSD, complex PTSD, or subclinical PTSD.
Yeah.
So just in listening to your presentation, I was thinking often about the role of PTSD and life traumas in that conditioned fear, the trait anxiety.
This is very important. We have a paper that we just got accepted. It's in press in the European Eating Disorders Review, where we show that that PTSD is very important, but what might even be more important is the adverse childhood experiences. Things that happened when they were young and they get carried forward. And
even if they don't have PTSD.
Yeah, I mean, the PTSD was not as strong, wasn't as strong as a factor. And some people, right, they had the ACEs, the adverse childhood experiences, but they may not have had PTSD anymore, exactly, right? Yeah. But it still has an effect. And in fact, and that's maybe where then the BMI question then also might come in, actually, because we know that BMI is associated with adverse childhood experiences. If we co-vary with the adverse childhood experiences score, then all the groups look much more similar in the eating disorder category. So this is maybe where part of the BMI issue comes in. The adverse childhood experience make people eat more, have a higher BMI. But if you control for those things, then maybe you find sort of a hypersensitivity also biologically across the board. So very important, and very important to focus on treatment.
Right. And that would go along with the, dopamine receptor density decreasing that we see in the striatum for people who have significant early traumas.
Density and or sensitivity. That's a tricky part, because the density we can measure and the sensitivity we cannot really in vivo. And I think that's where much of this discrepancy comes from that we sometimes see.
Great. Well, I just want to thank you one more time. I know we're a little bit over time today, for a wonderful presentation and just for all the work that you do for the field, research-wise, and clearly also for patients and their families. So
thank you so much.
Thank you very much. And thank you everybody for attending. Please reach out to Tammy if you have any questions, and we will send out the PDF of the slides, so you all have the references that Dr. Frank gave us as well.
Yeah, those will go out today, just so everybody knows. And yeah, thank you, Dr. Frank. And yeah, I'll send that out today, everybody.